what can we do to add to the gain of humankind? Are we going to be sitting and just accepting that, oh, this is bad and this has changed the dynamics and all that? And the answer is no. There's a lot we can do based on the deck of cards that COVID has dealt us to add to the gain of humankind. So you look at healthcare in Africa and you ask yourself, how is healthcare procured in Africa? And the basic tenet of healthcare procurement in Africa is the fact that most people go and they queue for healthcare. There is no system for appointments, or where there is, it accounts for less than 5% of healthcare procurement. There is no system for recall. There's no system for avoidance of primary healthcare contagion. Because once you're getting people to queue, you are increasing the likelihood of human-to-human transmission. Before COVID came in, that wasn't too much of a problem. Yes, it was a problem with the likes of tuberculosis. It was a problem with the likes of SARS. It was the H1N1 and other respiratory viruses. But they haven't been that endemic in Africa. So even if you look at something like MERS, even though it's known to be found a lot in North Africa, because camels are transported irrationally from the north to the Middle East and not the rivers because of the cost of camels and all that, the MERS is not coming into Africa and becoming a lot of a problem. Rather, it's going into the other parts of the world because tourism takes them to visit the Middle East, Saudi Arabia and all that. They go and ride the camels and they'll pick the virus and it would go. But COVID has dealt us a different set of cards where it has come into our continent and it is asking questions of us around, is the way we procure healthcare fit for purpose? Which then brings us to the point where we ask ourselves, what are the different points of healthcare procurement in Africa? And there is the infectious disease procurement of healthcare, where you have malaria, you have typhoid, you have cholera, you can name all the infectious diseases, and you go and you want a cure. And therefore you have malaria and you take a combination antimalarial like lumefantrine and artemether, and you get a cure because your plasmodium load drops and you get a cure. You don't need to bother until the next time that you have a temperature and you test for malaria and you realize you have malaria. That's one form of procurement, which is the infectious disease. But because under 5 mortality has dropped, infant mortality has dropped, vaccination has gone up, life expectancy at birth has increased because less people are dying within the first 5 years. And with that has also decreased the risk of infectious diseases causing mortality, which then means that people are living past the 35 or 3 decades, 4 decades. And if you look in 1960, the mortality rates were high for these diseases, and life expectancy in Africa barely hit 40 years, at best 45 years. Now that has changed because all these dynamics have changed, chronic diseases are creeping in. With the chronic diseases creeping in, we're living into our 50s, which is a good thing. But then what's happening? Because of the chronic disease burden, we have a secondary hit from strokes, from angina, from aneurysms, and all that, which is then causing mortality, whereby the knock-on effect is a lot of us are being educated, but are unfortunately passing away before we can transfer knowledge to the next generation. So whereas in the West, where most of us live, we are living to 60, 70 years where you become elderly and then you become a mentor and all that and transfer your knowledge. We are dying in our 50s and 60s when we are still active, when we've not even had PhD students, many of them, to transfer our knowledge, for them to even challenge our thinking and all that. So with all this in perspective, when COVID came, I looked at it and asked myself the fundamental question, which was, is our health procurement system fit for purpose? And the answer was no. We cannot continue to procure healthcare by going to queue, which then brought in the use of technology. And that calls in for the likes of telehealth, telemedicine, remote diagnostics, and all that. And I then asked myself the fundamental question, is the average African investor prepared to invest in the African entrepreneur or the African thinker who thinks that we need to move the needle in healthcare procurement forward to design a system whereby we can procure healthcare remotely without risking ourselves to hospital-acquired infections, contagion, and also saving ourselves time. Because I don't know about other African countries, but I know that for Africa, for Ghana, for example, the average time it takes between arriving at a hospital and obtaining primary healthcare access and getting your prescription and leaving the hospital is 2 hours, 41 minutes, which poses a question around productivity, because the average person in Ghana who decides to go to the hospital means they are off work for the whole day. Because then you've got to have the time to commute to the health facility and the time to go back and procure their prescribed medicines. So how do we bridge this gap? How do we ensure that the people who are thinking about moving the needle are paid for? The honest truth is that we haven't gotten to the point where funding is the norm. And the conversations should be around how we procure this funding. And that is what I want to address now. There are a lot of organizations who provide grants, from the Gates Foundation, from the Ford Foundation, from Wellcome Trust, from angel investors who want to fund telehealth and health innovation. The sad truth is that they do not understand health procurement in Africa. And therefore, for most of them, they are trying to look at a model that fits the West. They don't understand that the likes of Africa has a huge informal sector.
Mm-hmm.
They don't understand that in most of countries, payments are either cash or through mobile money platforms. They don't understand that to the average African, obtaining healthcare is a challenge. They don't understand that for the average African, even simple things like obtaining internet bundle is an issue. And therefore, as entrepreneurs, as thinkers, as health leaders in this area, we need to begin to fashion a way to speak to the people who can leverage our thinking and fund these resources. And for me, what are the bottlenecks? The bottlenecks are major because the risks are high. A lot of the people who can afford this funding would want to take major stakes in any innovation that is going into Africa. Sometimes disproportionate to the people who are doing the thinking and the people who are doing the planning and the people who are actually doing the implementation. The larger question is, are you prepared to cede that amount of control? And I ask this question rhetorically because you have to realize that often, if you see that the majority stake, even as a thinker, it could get to a point where you'll be pushed off the company because majority of the people ganged up against you. What does that mean for African health entrepreneurship? What does that mean for the people who we intend to serve? These are questions that we need to think critically about. The other critical thing we need to think about is why the average African who is financially endowed doesn't see investment in health entrepreneurship as an option. Have we not sold this concept appropriately? Have we not gotten to them? Is it that those people with the wealth in Africa do not value healthcare in general, do not value their own healthcare, or do not see health innovation as a leverage for wealth creation? These are other things that we need to try and address. And so I would want to end at this point by setting a number of parameters. In fact, just 3 of them. The first is we are not going to be able to leverage healthcare from a technological standpoint if we don't have investment. 1. The people investing do not seem to understand what we seek to achieve. 2. And number 3, unless we bring number 1 and 2 to a confluence, we would still be left with this health model that puts us at risk of any future viral diseases. And that is the key that we need to turn. How we do that is the discussion I want us to move on to.
Okay. All right. Thank you very much, Dr. Asiedu. And gentlemen, you have heard him. any question you have, I mean, you are free to ask so that we can all, discuss it and see how best it can help all of us. Okay, Dr. Lord, you have some question?
Yeah, not a question per se, but a submission that it's interesting. The cornerstone of this whole idea of expanding this kind of health technology in Africa, and from my standpoint in Ghana, has to do with the entrepreneurs, right, that we have.
Mhm.
How have we sold the idea to them? I mean, do they really understand it? And if they understand it, then why are they not investing in this technology? So I guess for the players in the industry, it's the challenge to sell this idea to the African investor, to the Ghanaian investor. You get it? So that they will be part of what we are trying to achieve. Because without them, then it's difficult. From
Yeah.
my own personal perspective, from my hospital, I'm trying to, as the speaker was talking, I was trying to see, okay, what more can I do? I mean, do I have the resources to invest in this? If I do not have, I must be challenged to seek resources to invest in this. But I can only go the extra mile when I have a concrete understanding and I can see the immense benefit to my clients. And so I fully take on what he has said, and I hope to be more educated on it so that I can also sell the idea to any investor that I come across. And for now,
Okay. Yeah, thank you very much.
You see, I
that's
would
it.
say this to Lord. The point is, I understand Ghana, and traditionally, most people have thought of setting up a hospital or a clinic or whatever it is without realizing that, let's say, even if you set up the best hospital, well resourced, state of the art, in Accra or Kumasi, or in Cape Coast or in Takrady, it would at best serve the entire region because of your expertise. At best, people will travel from adjacent regions to use your facility. But that is the reach you have. Whereas if you had telehealth, you could be reaching Tamale
Mhm.
because people could be having consultations with you remotely. You could have simple things like an algorithm that could do your clocking for you and could allow patients to identify the level of care that they need. And you could be dealing with people in Tamale, which then means that you could expand your business because you could have medical assistants, you could have physician assistants working for you who could be taking the video consultations. Who should they then think that it is beyond their remit could be referring back to you as a physician. But more importantly, you'll be helping to address the bigger picture of the doctor wouldn't go to the rural area. Because if you have community health nurses, is it also not true that they could take the blood pressure, the temperature, the pulse rate, if they had digital equipment, even things like the malaria spot test, they could take HbA1c, which would then mean that if you had a centralized electronic health record, you could consult with that person without even the person actually visiting you, whether you're in Accra, Kumasi, Takoradi, or Sekondi, or Cape Coast. These are the opportunities that technology presents to us. In fact, it presents even more. Today, we have on our iPhones and Android machines the opportunity to take ECG, EKG, and all those things. Could you, and the beauty of it all is that a lot of them can even be interpreted for you by an algorithm. So you don't need to be a cardiologist to understand what it's saying. You just need to be a physician to be able to get the interpretation and prescribe appropriately. And you can do all these remotely. Have we thought of this? Have we thought of procuring simple things like remote ultrasound equipment, which can do all these things, which can actually see and to give to physician assistants, nurses, and all that, to take this information that can inform and increase the size of your clientele, which then means that you can be charging them for providing a service without them actually coming to queue in your OPD. And these are the conversations I want us to have. And therefore, if you are selling this to an investor, you are selling to that investor beyond your district, beyond your locality, beyond your region, but Ghana, and competing on a bigger scale. And if we can then package these things and sell it, I think we can vastly improve on the quality of health that the average Ghanaian receives, and also leverage that into revenue for our businesses.
Yeah. Okay, thank you very much. And maybe to add to that, Dr. Lord, there are various, opportunities within the sector, and it is for us to sit down and then know what you want to do. If you see the bigger picture, then you can decide on what to do. Now, the India, I have another speaker who will be speaking, I think on the 26th or so. When we met, he said he brought their products to Ghana to sell, and he gave it to some people. And what happened was the people were taking money from him to be, promoting the product for him in Ghana. But all this time, nobody bought the product from his agent in Ghana. So when we met, and I told him one thing, do the doctors know about the technology or how telemedicine works or what tools they are using? No. Some of them don't know actually a lot about this telemedicine. So until somebody who understands how these things work, go out there to tell them, oh, this is how it works, most of them will just not understand. So it calls for somebody who has knowledge about a system that can sell the idea to the investor so that he or she can be prepared to give his money into this technology that we are talking about. And that also means that we need physicians like you who should not just be physicians, but understand a lot about the technology as well, so that whatever you are recommending or whatever comes to the system, you know what it can do or cannot do for you, and then you can speak well to it. And so these are some things that, and I mean, these are the opportunities for us to learn and know the basics, then we can take it from there. Yeah. Oh, Mr. Ofori, welcome to the platform.
Thank you. Sorry.
Yeah. So that is it, because there are a lot, when you take Conference,
I agree. You know what? A simple example was when I came back from the UK, and I came back to clinical practice,
Yeah.
I told most of my patients that I want to cut back on my hours. So I want to do more phone consultations than in person. Initially, it was difficult for most of the patients because, you know, the traditional Ghanaian mindset that we've been alluding to. They wanted to come so that they see you physically, so that they see your face when you are consulting. But after, I think, 2 years down the line, now the idea has kind of improved. I now do more consultations over the phone from evening to night time, and
Yeah.
it's kind of stress free for me now because I don't have to be at the hospital at those odd times. And so we have to take it to the next level where the patients who can enjoy that comfort, be in their homes, and still be given the same quality health and healthcare. And so I really, I'm happy that I'm here, and I'm happy to learn from you guys so that we can together revolutionize the system. The more we learn, the more we are equipped to do.
Yeah.
So I wholly take on what you guys are saying.
Yeah. You know, just to chip in here, when I over here, I try to talk to the Council of Aged People so that they can adopt telemedicine for the old age people in their homes and all those things. So initially, the resistance I got was, oh, the elderly folks are afraid of computer. They don't want to get close to computer and all these things. But then when this COVID started, a colleague on campus told me that I mentioned it to her and she said, oh, my mother had the appointment with the doctor over the computer. Initially, she was hesitant, but later she enjoyed it. And I said, yes, that was what people initially said, that they want that human interaction. They don't want any computer to be in front of them. But with COVID coming in, people are understanding it. So this is the time for us to sort of create more awareness, let our people know that this is better. We can use this to deliver care to them. And so from here, then we can move on. But as we selling this idea to them, what are the appropriate technologies that can be used to deliver their service? We have to look for them as well. Then we can sell those things to them. And from there, you bring the investor in. Yeah, Dr. Asiedu.
I think the technologies are available.
Yeah.
What I think we failed to do is to find a critical mass of investment and speak the right language. Like Lord has been saying, here's a situation where he's left the UK and he's gone to Ghana and he's now using phone consultations. And he feels that it's stressless. But one thing he's forgetting is that it's more stressless for the end user, his patients. And why do I say so? Look, if you look at Ghana's medical data, our outpatient per capita, which is the number of times the average Ghanaian sees a primary healthcare professional, is less than 1. It's 0.98, which means at best, people see a primary healthcare practitioner once in 1.5 to 2 years. You and I know that once you go past age 35, this has to be quarterly because wear and tear has set in. And like I laid the preamble, and that was why I started from infectious diseases and all that, because I wanted people to understand that if you're not going to die from infectious diseases, which are curative, and you're going to want to live long with chronic diseases, which are preventative, then you have to do what I colloquially call MOT. Take your car for routine servicing, and your car is your human body. Because you want certain things that ordinarily wouldn't come as an illness to be picked up early. Because you can do with malaria coming as an illness, If you're a bit smart and you get your temperature and all that and you feel feverish and you go to a pharmacy shop and do the spot malaria test and take your anti-malarials, you survive. But a stroke due to uncontrolled diabetes or hypertension wouldn't give you a warning sign. It will hit, and if you're lucky and you survive it, you probably have slight loss of movement and all that. But if you go by the data with Ghana, where hemorrhagic stroke constitute about 98% of our total strokes, and ischemic strokes are virtually 2%, when the reverse has to be the case, you know that when it hits you, you're going to die in your 50s. So if you then have Lord coming to you and saying, I can get someone to you to take your blood pressure, to take your temperature, to take your pulse rate, to take your HbA1c. And then I can remotely get someone from the lab to come with a motorbike to take your blood, to go and do more tests around your cholesterol and all those other things. And on that basis, when you have finished work at your convenience, you can book an appointment to me. And between the two of us, we'll have a video consultation. And based on all the information I have about you, from the nurse who came to you, from the lab person who came to you, I can send a prescription directly to your email. Or if you have a pharmacy, I can send it directly to the pharmacy, which then means that you can not have to leave your market store, your business, because you are scared people will steal from you, and go at your convenience to pick up this medicine. And I'll check with you how you take that medicine, because the nurse will come and see you 3 months later, take your blood pressure, your pulse rate, your blood HbA1c, your fasting glucose and all that. And I'll be able to know how well you're doing with your medication, how well you're complying. 99 out of 100 market women in Ghana would go on such a system.
Mm-hmm.
You see, and if you then modeled this and sold it to a businessman who wants to invest in a huge hospital and said, you build this huge hospital, you probably build it in Cape Coast, but it would at best serve the entire central region. If you've invested in this and we did it properly, we can serve the whole of Ghana. You have patients from Tamale. Probably they would understand you and go with you. And I think that is the conversation we've not had around funding. And that's why I haven't tried in this conversation to talk about funding sources, because we all know the funding sources. We are going to them and we are not getting them to fund us. The question is, why are they not funding us? That is what I wanted to address. And it is because we are not selling the model properly.
Mm-hmm. I think that makes sense. That is one key point. I believe so. Because definitely he or she is an investor, okay? And before an investor decide to invest in something, he has to look at the return on his or her investment. But if we don't actually sell the model that we want to adopt in our country to them, no. And so that is where, like I was saying, the doctor must try to understand some technicalities, understand some business people, or as a private hospital, you can take a finance manager to be able to do the analysis for you, cost everything, and then if you all go through the document and see that what this is workable, then you can, with your document, approach an investor. Until then, I think it will be a huge challenge. Because from one, I keep saying, for the government in Africa to adopt telemedicine or telehealth, that will be a huge challenge. It will not be now. But the private hospitals can try this. And it means that you have a proposal well laid out, then you present to the investor. Because we want to know what is my return on investment in your facility?
You see, Evan, you've made a very important interjection. And why do I say so? A lot of our health facilities in Ghana are dependent on the NHIS, even though it doesn't pay regularly.
Mm-hmm.
Right?
Yeah.
And the cost per head is high because the average clinic has to pay rent, has to pay electricity, has to pay water, has to have records department, has to have nurses to manage. If you have that and you have an allied telemedicine system, you are not paying for all these things for all the remote consultations you're doing because your EHR is online, your consultations are online. You don't have to pay a security man to guide the cloud and all that.
Yeah.
But more importantly, your cost per head will drop. When that happens, and you have a large number of patients, you can then approach the National Health Insurance Scheme and say, look, this is the number of patients I get. This is the cost per head I have. I'm prepared to provide a service to you at this cost, which is much lower than anyone can provide. But more importantly, in doing so, I'm going to increase your reach, which then means that the coverage of the National Health Insurance, which has been 36-37% for which history knows, can quickly start accelerating. At that point, they would want to come and talk to you, not you, because you have the data, you have the investment, and the people are paying private anyway. And the politician always wants a winning card. So what would they do? They'll jump on the bandwagon. And these are the investment, and that is why I said I'll speak about the cost capitalization and investment. Because unless we start thinking through these things and start forming small groups to discuss how we can move these forward, we'll still be in this silo mentality. I have my clinic, I have my hospital, I expand, and I built another 2 blocks, and I had another 50 patients coming in, and I'm making money. When you could have actually had about 5,000 patients coming in if you were electronic. And these are the things that we need to look at.
I agree.
I mean, I have some, contribution to make, not really in the area of investment, but more in the ecosystem, I mean, way back 20 years ago, I knew that my aunt was, living in the UK, and she could actually travel and receive her prescription sent to her by post back to Ghana. This is just one example. The second example is, if a typical Ghanaian is not feeling well and you talk to the person on phone, take a temperature. I mean, describing symptoms. They sound very, simple, but we are not really educated on these lines. And if the target audience is the rich, that is okay. But if you really want to meet the critical mass, there is a whole lot of citizen engagement or education that needs to be, propped up. Otherwise, I'm not saying that it will not be successful, but it will be quite an uphill task to try to implement this in this kind of current situation.
Jonathan, you make a very, very good point that I've addressed as a professional speaking to a number of people on this subject. And why do I say that? If you are someone who works in the area of health, I live in the UK, and I'm quite sure a lot of you living in Ghana, how many times haven't your aunt, your uncle said, oh, this my nephew or niece or brother or son is a doctor, and you are not well, and then they pick the phone and call you, and they tell you the symptoms over the phone, and you're able to tell them, oh, go to the pharmacy and get this, or at best you tell them, oh, I want you to go and do this lab test and all that, and when you do it, send it back to me, and then we'll move forward. Look, the truth of the matter is we haven't known, but we've been practicing telemedicine because of our limitations for generations. Generations. We didn't know. The only difference is that it's been given a name now. For as long as I remember, when I was a kid, when we came back from the UK and were living in Ghana, and things were hard around the 82, 83 when I was in Adisado College. A lot of times when I was unwell and all that, my dad, who was a professor in KMSD, would say, seeking a second opinion from his brothers and all that, and call the United States and speak to his brothers. And they say, oh, go and do this test, go and do this test, and let's talk about it. We still do it today, 40 years down the line. So we shouldn't underestimate the things that we have been doing as part of our history, and accept that they are antecedents to where we want to get to. I hope, Jonathan, you get where I'm coming from.
Well, I mean, I get your point. I grew up in the, between the town and the village settings, and we lived mostly on the self-prescription.
Yes.
If you're not feeling well, the pharmacy is two houses away, and my dad just you just walk there and just go and buy chloroquine and take a tablet for.
Thank you.
And that's it. I mean, I'm just saying that to get into this area on a mass scale. There is
Jonathan,
need really to.
But let me stop you there. You've made another brilliant point. Why haven't we been able? Look, the point you've made, you were living 2 houses from the pharmacy and you were doing this. In that same time, there were people who were going onto buses, onto trains, and selling medicines, and people were buying by word of mouth without any interjection. The point is that we haven't put the pieces together. All I am trying to say is that the things that we have done as a part of our medical oral history is enough evidence that if we are able to plan telemedicine right, we should be able to get the funding to be able to leverage it to the benefit of the larger population. Because if you were going to this pharmacy, and often it wasn't even a pharmacy, it was a drugstore, because there was no pharmacist there, and trusting that that person was going to, so to speak, use informed decisions to improve on your outcome using chloroquine or whatever anti-malaria they used. How can we not be prepared to accept that more informed and intelligent people who have been trained in the area of health, leveraging, and one thing we have to realize is there are so many nurses, there are so many nursing assistants sitting at home who've been trained who don't have employment. And if you just use a simple model of something like Uber, they can come and take your blood pressure, they can do malaria tests, they can take your pulse, they can do all these things. And the doctor can talk to you remotely. Is that not better than the pharmacy that you were going to, or the drugstore, because there was no pharmacist, like I said earlier? 2 doors away. Is that not going to give you a better service? Is that not going to give you value for money for the money you are investing? And these are the things that I am trying to say that we haven't sold to investors, and therefore investors are not aware of the benefits and therefore would not put their money in.
Well, I mean, maybe I was coming to a third point, and it's I'm just not touching on the investment side because for me, it's more of the model that there's not, somebody has to package this in a form that makes people accept it, that makes people know that this is a differentiator in terms of, I can get a better service doing this, even though I could just walk to the pharmacy and that kind of thing. I mean, I could rely on a system which is efficient, something that I know. And I think, well, investors can basically, say that, okay, I want to invest in this area and all that. But how much of it in terms of the whole modeling? When I say the modeling, it's just like you have a Facebook just came up, or WhatsApp came up, or you have all other these kind of applications that are used by so many other people and that kind of thing now. We were talking, using phones and all that, but these technologies are leveraging on the social interaction and creating this kind of platform. So for me, it's more of the kind of ecosystem who is putting, somebody needs to blend all these things together and put it together for use. And then you can approach an investor and show how viable this is in terms of an investment vehicle.
Jonathan, thank you. That is why we are on this call together. I always tell the story of whenever you say someone, nobody does it. Mm-hmm. Now that we are having this conversation, and you have identified the viability, and you have identified the options, and I'm talking about the opportunities. Eben is talking about something else. Is it not possible to put all this information together and package it to the point that it will be acceptable to an investor? I think it is.
Yes.
And so don't let us underestimate the level of intellect that we have independently. The problem we've had as a country like Ghana is that everyone wants to act in a silo. But that wouldn't work. And that is why I agree with you. But if we can continue to have conversations like we're having today, and we can then, on the basis of those conversations, have a package that sells, do you think an investor wouldn't buy? At the end of the day, what's an investor looking for? Returns. So you are making very, very relevant observations and a relevant interjection. But that informs us to the point where we have to say, what next? How do we get the funding? And that was why I structured this whole conversation about funding the way I did, by talking about historical antecedents, what has been our disease burden from infectious diseases to what our disease burden is currently, what has been our social anthropological behaviors, and how those fit into us using technology as a means of improving healthcare, but more importantly, as a job creator and a revenue earner.
Yeah, thank you very much.
I want to come in here.
Okay, you come. Yeah,
I see a conversation with the Ghana Medical Association, in the case of Ghana specifically, as very important in this conversation, because many doctors have signs they do free consultation on phone without any revenue.
Yes.
And as much as the profession is a noble profession, and as much as you want to help people, but if we can have a framework with which there can be some revenue production from this service, then it's something in the right direction. And I'm sure the people who have enjoyed the free service would not mind paying something small for the service.
That's it.
So
Lord,
I think
right.
The Ghana Medical Association.
Lord, you are 150, 200% right. That is the
Yes.
point I've been making about our anthropological antecedents. We've been doing this for free, as doctors especially. As how many times haven't people called you and gone for antenatal, Lord, and called you and said, oh, this, that, and you've told them for free? Family,
Oh yeah,
friends.
it's the norm in Ghana.
It
It's
is.
a norm. But what to
Yes.
make
And
money now?
that is why I'm saying that this conversation is important. And that's why when Eben approached me, I said I would speak on this subject, not because I wanted to give out my knowledge for free, but it was an area where I felt that we have underestimated our ability to provide more to a country that needs more. Look, we have only close to 9,000 doctors. Our doctor to patient ratio is about 1 to 9,000. Our nurse to population ratio is ridiculous. Our midwife to population ratio is 1 to 13, 14,000. Why are we surviving? We are surviving because of these things, Lord, you're talking about, that 1 to 9,000. You are not seeing 9,000 patients on average because maybe even you've gone to have a beer or something, and then you are sitting with your friend having a chat, and then they'll go, oh, I was talking to this friend of mine. I say, oh, you call them, and let me have a chat. You don't realize sometimes you even spend longer on the phone consulting with that person that you spend actually in your consulting room talking to a patient who is paying you. Am I wrong, Lord? You are talking to the person.
That one is very, very true. It's too true.
And then at the end of the day, you even send them a prescription by WhatsApp. Yes, you don't sign it, but you think, oh, this one is free. Oh, go and get this.
Often.
And then they take it to the pharmacy. And the pharmacist might say, oh, it's not a valid prescription.
Sorry to cut in, but
no, go on.
These days, we even review laboratory investigations. So these days, we review their lab investigations on our WhatsApp lines. We do follow-ups on WhatsApp, and all for free.
Yes.
Because it's not everybody who can come and meet you at the hospital. It's
a
friend's friend, a church member, all of those things.
Lord, so now you are buying into why I was telling you of the fact that the issues about packaging and looking for investment. Because, Lord, let me ask you a question. How many times, where are you practicing in Ghana before I ask my question? That would be helpful. Which part of Ghana are you?
I practice in Accra.
Okay, but I'm quite sure you've had conversations with people from Takrady, Kumasi, because they are church members' friends.
Oh, yeah.
Has it crossed your mind that if that person was on a telehealth platform and even you are charging them 10% of what you charge for your average customer, it will still be revenue because you are using your time and your intelligence, which you paid for? That is what I talk about. We haven't been able to package this and sell it to the investor. And that is the conversation I want us to be having. Because if anything, COVID has taught us one thing. Our current health procurement model is an affront for disaster with respiratory viruses. And we need to think, and if it's even unsafe for us as health professionals. Because let's ask ourselves, Lord, if you could review someone's lab results by WhatsApp or on a telehealth platform, you could get in their blood pressure, their pulse rate, their HbA1c. You could get in their lab results, fasting glucose, random glucose, AST, and all that. And you were not sure if the person carried COVID, and you could consult with them on Zoom, Google Hangout, like we're doing now. Would you want the person to come and sit in front of you and possibly infect you? Would you want that? The answer is no. But we haven't thought of it that
Oh,
way.
nah. Never.
So you see why I see telehealth as the opportunity. And the other thing you have to look at is from a professional standpoint. Currently, you practice in Accra. You probably have to see all these patients. Could you not have had physician assistants who are now being trained a lot and are sitting at home because the Ghana Health Service cannot employ them? Taking these teleconsultations, you reviewing the consultations because the audio conversations have been stored on a platform, and then looking at the prescribing habits and going, well, no, I wouldn't have prescribed this, and recalling patients based on what you are not happy with, and giving a better quality of care because now you can spend more time looking at the patient care records rather than being impulsive and every time. Would that not serve your patients better? Wouldn't that give you a lot more reward? Wouldn't that improve the life expectancy, the quality of adjusted health years of your patients? Are we having these conversations?
You see, you are so spot on. So spot on, because personally, and I'm speaking from personal experience, I was fundamental to the training of some physician assistants when they were doing their clinical attachment about 7 years ago or so. And now that they are practicing, most of the time they call me and I review their
Thank you.
patients with them. So actually, if I've got more info, like you are saying, stored, and then I can review a better health record of the patients, then I'll provide a better feedback to them rather than the knee-jerk calls. And
apart
so
from,
we are just going in the right direction.
yes. And for me, that is the only reason why I accepted to speak about these things, because I've always told myself, and the few times I've interacted with the likes of Eben, I've said, there's no point in having this body of knowledge in one's head and sitting down and saying we can do more. I'm one person who is not scared about sharing the knowledge because there is so much we can do by having these individual conversations. And as a result, expanding healthcare provision in Ghana beyond what any politician, any government would do, but more importantly, earning revenue for each other. So I would want to say, to seek funding, we need to first and foremost package our offer. And all this conversation is about the package we can provide.
Mm-hmm. Yeah. Good point. Yeah, thank you. Yeah, I was even saying that, like Lord was saying, can we identify what to bring onto a telehealth platform? You look at your facility, what services do you think you can easily bring onto a telemedicine or telehealth platform? So when you identify those services, then you see what are the appropriate technologies, and then you look at costing as well. So these are things that, I mean, calls for brainstorming as we are doing now, and then we take from here forward. Then we'll come out with a very nice package. Then we can present it before, an investor. And I believe strongly that whoever the investor is may also be interested in, coming to do business with you. Yeah. Because
And that's the way to go.
yeah, yeah.
That's the way to go. I, with some colleagues, have been working on something. And at a point, I'll share with all of you. Not at a point, I mean, in the next week or two.
Okay.
Yeah, I will share with all of you because we've got a detail. In fact, part of the whole model is to cut out a lot of frontline and use AI to actually triage the patients to start with. But it is something that is doable.
Yeah, I agree. I agree.
And you see, we shouldn't underestimate the average Ghanaian. I think a lot of times we underestimate. You see, we grew up in an environment where, for years, the reason why we said the banks couldn't go to the rural areas was that they wanted to keep their money under their bed. But someone woke up overnight and came up with Momo. And suddenly the market woman prefers Momo than you giving them cash. Now COVID has come. And COVID is telling us that it can stay on solid surfaces for up to 72 hours. So money is even not an option. So most people would prefer paying by Momo anyway. If you look at the data on Momo, since its inception in 2011, there's no single year it's not grown by more than 200%. Health can do the same thing. It's just that we've not brought our minds to it. Mm-hmm. And I believe through this platform, we should bring our minds to it. We can get the funding and we can blow that system.
Yeah, thank you. Yes, thank you. Jonathan, have any question? Jonathan? Oh, okay. I think they are gone. All right, if there's no question, maybe we'll have to be ending here. And Dr. Asiedu, I want to thank you so much. I think it's not ending. We need to get to part 2 of this discussion. And so we'll look at it maybe ending of this month, the last Friday in the month. If the other guy may not be able to present, then we can fix you so that we continue with the discussion.
Yeah, Ben, we need to have these discussions,
yes,
because there's a lot we can do.
Yeah.
And for me, the more we have these discussions,
yeah,
and the better an understanding we get, because we all have our strengths.
Yeah.
The problem with Ghana, I've always said, is people are scared of their weaknesses.
Mm-hmm. Yep.
And want to play on their strengths. And so we have a lot of silo mentality. But we need to look at our weaknesses and get people to plug our weaknesses so we collectively become strong.
Okay. And Lord, as you were saying, I mean, one thing is if we can find a way to engage the Ghana Medical Association, because from that perspective, it can trickle down to the doctors. Because if the association at that level try to create an opportunity for us to discuss some of these issues with the doctors, I believe that they will buy into it as well. Well, what do you think, Lord? Oh, okay. Hello, Lord, are you over there? Okay.
Okay, so yeah, what I'll do is, what? Can you hear me?
Yes, we can hear you.
Can you hear me, please?
Yes, we can.
Okay, so I'll refer you to some of the executives. I'll also send this webinar that we had to them as an evidence of what we've been discussing. And I'll tell them about the importance of getting to know about this. And maybe they can put this webinar, they can invite you to have a CPD with us. And in the CPD, we share these ideas. Doctors get educated on the importance of telemedicine and then the implementation of telemedicine in Ghana. Also, the Society of Ghana Private Medical Practitioners, Private Medical and Dental Practitioners, is another organization that would benefit immensely from this. And I think they are a major stakeholder, especially from the private facilities perspective. So they will also be a good stakeholder to engage.
Yeah. You know, like I was telling you earlier on, I from the word go, I said, look, the government adopting telemedicine or telehealth will be a huge challenge. So I decided to work with the private sector. So I talked with the church. I mean, is it the Christian Health Association, so that we can see how best we take it out from there. But then it couldn't move so far. But then if the private people can adopt it, and government see that, oh, it's working with the private person, obviously they will come into it. But until then, the government will not be serious and people will be dying. Meanwhile, we also need money to be able to, function. Yeah.
Yeah, so I think that's fine, Lord. If you get that done, I'm always willing to share my ideas, because when I share ideas, I learn.
Okay.
There's one thing that, if anything, that I learned in graduate school and in research, is the fact that question storming and idea sharing is the beginning of knowledge evolution. And therefore, you might call it as a CPD for you, but it might be a CPD for me as well.
Yeah.
Because the very questions that people would ask, if we don't have answers, we go and read, we go and research. That's learning. And the only way we are going to develop that country called Ghana is if we are willing to learn. Our biggest problem has been, this far, we've struggled with our convictions to learn. And that needs to change.
Yep. You're right. Okay.
Okay. So
All
let's
right.
Yeah,
leave it.
so true.
Yeah, so let's leave it at that. Thanks everybody. It's been great us talking, and let's keep this going. Don't
Okay.
let us make this just a one day wonder. It
Oh no,
needs
yeah.
to go and build.
Yeah. I think we can start maybe, I mean, after June we can do it twice a month going forward and see how we can mobilize the resources for the next other thing. So that is it. Thank you very much, Dr. Asiedu, again. So next week, God willing, we'll be talking about how telemedicine can improve